I'm going to go ahead and hit the recording and we will get started. So thank you to everyone who's joined so far. We do expect we'll continue to let others join in the meeting as we get started. But today is the final of 4 child abuse and neglect prevention trainings that we are hosting this year as part of our series. Today's topic is social determinants of health, something I know very near and dear to many of our hearts. I will give us some general announcements and then turn it over to our team of experts. We want to thank them all for being with us today. So we've had Dr. McPherson for all of the trainings. And then for our content today, Dr. Joel Davidson, Dr. James Duffy, and Jessica Saunders are those who are going to make up our panel to share some of their resources and expertise with you. Our general announcement. A reminder, we will be muting lines during the presentation, but we do have scheduled times when we'll take breaks for questions as time allows. If you have questions that you can send in the chat box, we'll also moderate and ask those and try to get everything answered. If we don't answer a question during today's presentation, we will be following up and getting answers for those from our team afterwards. CME statement, this program has been approved for a maximum of 3 hours of PRA Category 1 credits, and you will receive information following the training day to your CME credit through an evaluation link, and you can complete that to receive your certificate. We'll also be sharing the resources from the presentation. Our presenters have no financial relationships to disclose. No off-label products will be discussed during today's presentation. And we'd like to thank our program supporters. So the Office of Criminal Justice Services has been our supporter during this series, as well as the Ohio chapter, American Academy of Pediatrics. Thank you to our presenters for today, and of course to all of our attendees. And with that, I will turn it over for introductions to our leader, Dr. McPherson.
Thank you very much, Haley, and good afternoon, everyone. We are so glad that you're with us. As Haley mentioned, this is the final webinar of our series related to child abuse and neglect. I'd like to thank Haley and Olivia, who's not joining us today, both from the Ohio AAP, for the wonderful work they've done with planning, logistics, IT, regarding these webinars. They've been very successful, and we anticipate a wonderful presentations today. I would like to introduce our first presenter. This is Dr. Joel Davidson. He is a general pediatrician at Akron Children's Hospital, working with patients and families at the Locust Pediatric Care Group. An Ohio native, he grew up in Columbus, Ohio, received his undergraduate and medical degrees from the University of Toledo, and completed residency training at Akron Children's Hospital. He's also an associate professor of pediatrics at Northeast Ohio Medical University. He began his career in the community pediatrics as residency education coordinator, and now he serves as the patient-centered medical home director for Akron's network of primary care offices. He co-chairs the hospital's Social Determinants of Health subcommittee. He and his wife have 3 children, and they've been coping with the pandemic by trying to earn their first fall hiking spree badge. And on a personal note, I know this has been a topic near and dear to Dr. Davidson's heart. A few years ago, when he was beginning this initiative, Akron Children's Hospital, he and I spoke briefly about the connection between social determinants of health, adverse childhood events, and child abuse and neglect. And I'm very grateful for him personally, for our hospital, for the great work in identifying and advocating for the continued screening that has been so successful here. So Dr. Davidson, the floor is yours, and thanks for being here.
Well, thank you, Paul, or Dr. McPherson, and also echo the thanks to the AAP planning team. Good afternoon, everyone. Thanks for having me. I hope that we can share some wonderful things around social determinants, and I'm really excited about the audience, the collective group that we've assembled here and done so virtually. We're all kind of moving to this model now. I think that I'm hoping that this conversation fits nicely into the discussion that you've been continuing to have in your group related to child abuse and neglect management. I am glad in this discussion that you've already talked about implicit bias. You've already been somewhat on your way in understanding and approaching social determinants of health. Can you go ahead and advance to the next slide? Or you know what, I'm going to try to just take control of the screen so that I can advance them here.
Yeah, feel free. I've got them ready just in case, but go for it.
Great. So let me know when you can see.
I've got it right now.
This wonderful girl drawing a picture of a house. Wonderful. Okay. Oh, there we go. All right. So for today, I wanted to give you an overview of where we're headed and what we're going to be covering. So the objectives you have in the announcement: understanding the impacts of social determinants on lifelong outcomes and increasing your knowledge of tools and opportunities to identify social determinant needs. We are going to structure this time together in really three major areas. I'm going to start with the first one and talk about just an overview of social determinants, health disparities, inequity, toxic stress, and talk a little bit about some of the available social needs screening systems that are out there. I'm going to turn that over to Dr. Duffy, who's going to talk about resilience and the impact of screening on childhood health outcomes, including its connection with the foster care community. And then lastly, Jessica's going to finish us out today and talk about practical steps that offices can take in setting up screening and addressing those responses that you get from screening. I want to start our conversation by thinking about who matters. The root of this conversation is in our relationship that we have with patients. And if we keep the patients and their families at the fore as we address some of these challenging and often somewhat daunting experiences within the domain of social determinants, I think we're going to hit the mark. And I think that you will hit the mark in your clinical work as you address those families, as we look to work with them, as we look to value who they are, what they bring to their own lives, and what they bring to our relationship together. Everything is about relationships and social determinants, and that relationship is built on a mutual trust and an understanding that we as care providers are there to help the family and in pediatrics, the patient. And lastly, for us, I think it's also important that we keep our eye on making sure that what we're doing is actually improving the outcomes of the people that we're hoping to help. So you can't have a conversation right now without talking about COVID-19. And COVID, really, the virus itself, I'm not going to talk much about virology, but the pandemic response and its impact definitely has a lot to do with social determinants. We know that this has been a really costly pandemic throughout the world. It's costing upwards of $10 trillion. And we'll have many more economic fallouts and costs as the future years begin to unroll. Here in the United States, we've seen an increase in food insecurity reaching nearly 40%, basically doubling the amount of food insecurity that was present in most of our communities. Unemployment at the peak of the pandemic reached 14.7. Depending on what numbers that you look at, we're looking at somewhere between 7 and 10% now. And obviously, we lost about 22 million jobs at the peak of the pandemic, and good for a lot of reasons. We've gained back maybe 10 million of those jobs. However, if we look at the amount of jobs that have been gained and by whom, we're really leaving out women. Some people have called this a she session, a play on words off of the recession, but largely impacting the employment of women. And we know that women are often the heads of households for a lot of the pediatric families that we're thinking about and carrying along with. We know that the pandemic has had a disproportionate impact on morbidity and mortality in communities of color, having higher rates of deaths in African-American populations is certainly something that we all have heard about and know is true. As it relates to somewhat of this discussion around child abuse and neglect, the amounts of anxiety and depression are also nearly doubling and continuing to rise rapidly in the midst of this phase of the pandemic, as we all hit the pandemic fatigue. But the depression and anxiety rates in both parents and kids are real, and are part of this pandemic. The digital divide, we are all sitting here today, all connected to meaningful technology with adequate, most of the time, internet connection. We know that kids in underserved or kids in vulnerable populations or pockets of our community do not have the access to those technologies in the same way. We're noticing that already on the clinical side of families that have access to virtual visits and the benefits that go along with that certainly favor more affluent parts of our community. As I look at school, I think that school is an important thing that worth noting in this discussion around pandemic response. I have some kids that are in hybrid models, some kids that are in full in-person models at school, and some kids that are in full virtual environments. And the delivery of education and the disparities that go along with them certainly are highlighted in the pandemic. And then we have the things that are coming up in the future. We right now have seen, really honestly, some good things that have happened in response to support, some poverty that has been averted because of stimulus and other kinds of things. But eviction, we've really operated in this pandemic since March in a housing first policy, keeping people in their houses and not evicting them. But that pending eviction flood is going to be real. And I think that, these connections with the pandemic and what's happening make social determinants a pressing issue and something that we're going to make sure that we need to figure out before too long, because it's going to have continued effects on our kids. So the discussion around social determinants really starts with inequities. And I start with the word inequities because there's equality, which we sometimes equate with equity, but equity are those inequalities that are thought to be unfair, unjust, and avoidable. And disparities, health disparities, are the type of health difference that's linked to social, economic, and environmental disadvantages. The reason that we're talking about social determinants right now in 2020 is not because social determinants as a concept is new. We've known about this for really from the 60s and 70s, when the early research connecting place-based influence on outcomes was known. We are talking about this now because the disparity in the outcomes that we see in healthcare have really become the thing that we're trying to address. And social determinants screening, as we're talking about, so we're going to talk about definitions in a little bit, but approaching these issues in the office, in the medical setting, we know is really to get at the disparities that exist. So the Institute of Medicine has 6 aims for improvement: safe, timely, effective, efficient, equitable, and patient-centered care. And I think that it's important to note along the way that I've been putting some references at the bottom of my slides, knowing that this is a really, really big topic content area. If you're interested in finding more, I've left those references for you as kind of guideposts that you could follow if you're interested in reading the full the full articles. But this this white paper really does go over how healthcare organizations can approach making care more equitable, and certainly connects to our discussion around social determinants. If you look at number 3 in this framework that they've outlined in that paper, deploying specific strategies to address the multiple determinants on health in which organizations can have a direct impact. We are in a really tense, divided time within our country. You guys are all know that. We're all waiting to kind of see what happens in a couple of key states, and looking forward to a way that we can, a time that we can eliminate some of that divide. And all of your work, I'm sure, in some way is connected to attempts to address the multiple disparities that we have. I look at the picture on the left. I took both of these. Well, I guess I didn't take the one on the right, but I was present in the one on the right. But the picture on the left, I did take this picture, and you can see that it looks bright. The stream is flowing. The sun is shining through the trees, and it's a peaceful, serene image. This image is actually taken on a very sturdy bridge across the divide that exists right before the water falls over the edge at the base of this picture in the Cuyahoga Valley National Park at Brandywine Falls, which is in this Northeast Ohio area, one of our more famous landmarks. But I equate this issue of diversity or disparity with the different vantage points that patients and families have, and oftentimes different than some of the vantage points that we have as providers and healthcare systems. With what happens at the base of that waterfall. The base of that waterfall has a very different view. In my mind, I think of a time when my family and my brother and I went to Yosemite Valley with my dad, and under Bridal Veil Falls, one of the biggest falls and one of the biggest, largest rock formations in the United States. We were playing on these really large boulders. They were slippery. We would dunk into the water. And in retrospect, it was probably pretty dangerous that we were doing this, although we didn't really realize that was that dangerous at the time. But to think about the work that happens in our own situations where families, we're trying to get them out of that rocky bottom with water just splashing and running into their lives and kind of disrupting things on a fairly regular basis. What it has to take to move them, move along with them out of that space that is treacherous into a space where they feel a little bit safer and more confident, is really what we're after. So I'm going to switch now and talk about some of the resources that are available to understand disparities. I made a statement before that almost no matter where you look, you can find disparities. I have the AAP journals, kind of in front of me here, and they're talking about breastfeeding rates, just arrived on my desk today. There is a disparate amount of breastfeeding in white children and Black children. And why do we have that? Actually, breastfeeding is doing a little bit better, and they're making some progress there. So good work if you're on those teams. But I'm going to spend the next couple of slides just going over what is available as you look at disparities in your own communities. And there's a lot of information out there that you can certainly explore somewhat on your own related to data and data management on specific questions. This first slide shows childhood poverty. And if we look at the percentage of children in poverty in 2018, you can see that the total is hovering around that 20% mark. It depends on which location you're talking about. And actually, the last decade made some progress in this realm. This is, again, children in poverty being less than the 100% federal poverty level. What we really need to look at is probably 200% of poverty level or more to really get to, depends on the family size, but really to get to our families have enough resources to address all of the things that they need with bills and food and housing and education. It's astounding to me that we have nearly 20%, 1 in 5 kids that are defined as living in poverty. And we have 40 to 50% of kids that live under a threshold where they can't make ends meet. That is a tremendous amount of pathology. I challenge anyone to find, other than dental health, a disease process that has that much prevalence. So there's more at childstats.gov that you can explore on your own related to understanding the impact of childhood poverty. And Jim Duffy was a co-author on a 2016 paper that gives an excellent overview of the issues of childhood poverty. Next, I'm going to talk a little bit about the Child Opportunity Index. It's now a Child Opportunity Index 2.0. This index it basically combines a lot of neighborhood level indicators to give a composite score for that area. And those 29 indicators cover education, health and environment, and social and economic factors. And I encourage you to go to their website and play along play with some of the ways that they allow you to display information. What I'm showing here is just one of the examples of the percent of children across neighborhoods by opportunity, by race and ethnicity, again, highlighting this disparity. And really what you want to show is these green bars are white Caucasian children, and the dark blue bars are Black or African American children. And you can see that there's really an inverse relationship here. Neighborhood Opportunity Index increases, for white children, and it decreases for Black children. This is a data set that I created on my own just for this slide from Kids Count, the kidscount.org. And it just looks at over COVID, since March, adults living in households with children who lost their income. And you can see the entire United States is in orange, kind of hovering around 55%. And you can look at the different states and how those states varied: Ohio, Pennsylvania, and Michigan. So I encourage you to check some of those things out to learn a little bit more about specific disparities that your work connects to and connects with. I tried not to highlight too many disparities for a couple of reasons. One, I find it very difficult to continue to read some of that literature, which always shows a disparity. We have not gotten to a place that we need to related to what we need to do to address those disparities. So I challenge you in your work to continue to push the envelope to work on ways that we can reduce those disparities. And just, the theme of today is to start with something. But let's move now to talk about some of the definitions. There's many different definitions of social determinants of health, and a lot of them sound very similar. I prefer the World Health Organization definition, which I've presented here. The images are from the Healthy People 2020. Their definition is a little bit more restrictive, but social determinants of health are those conditions in which people are born, grow, live, work, and age. And they're shaped by the circumstances are shaped by distribution of money, power, resources, and at all levels, global and national and local levels. And social determinants of health are mostly responsible for these inequities that we're seeing in health outcomes. I think that most people are familiar with the framework that is presented by the Healthy People 2020 initiatives with these images, but it's good to break these up into overall domains. So the domains of economics, education, health and healthcare, neighborhood and built environments, social and community contexts. And this is a fairly simplified view of one model or framework. There are a lot of different frameworks that exist around social determinants. And one of the challenges of the word and the concept of social determinants is that sometimes and incorrectly, we assume that the social needs that someone has automatically and will by default put them into a category of poor health or poor health outcomes. And that we know that that's not really true. And so we move into kind of a different definition, something called a driver of health. And in these frameworks, these are modifiable factors that are involved in what it takes to be healthy. And one of the concepts that we want to try to convey is that you want to keep things a little bit more positive, recognizing that families do have some strengths within their area of need, and that this kind of concept of a poor health outcome is not something that's going to be that's going to be certain, especially for that child or for that family. But in the drivers of health models, I point you to this paper. They really talk about what are the influences of health outcomes. And you're probably familiar with the understanding that health care itself only is accountable for 10% or a smaller portion of actual why that patient has that outcome. There's other factors with social and behavioral factors playing a much larger role. And this scheme kind of gives you a better idea of how those factors are involved in the outcome that you're looking for. And I don't think that this is the best example as it relates to pediatrics, but it definitely relates to the impact of indirect factors, direct specific things, and then the outcomes that you're interested in looking at. And so for that reason, I like kind of the way that some of these, the way that these authors have put this concept of these are the factors that you can change that help to improve the outcome that you're looking for. So what we're really talking about today is when we talk about social determinants of health screening, is we're most of the time talking about identifying social needs that exist within families. And there's also an element of social risk. So what is it about the child and family that we're seeing in terms of where they live, what influences are present in their life that may put that family at increased risk compared to other kids within that same community or within other kids within that same clinic or hospital system. I put this slide in for a couple reasons. One, it I think gives good flow of the definitions that we're talking about with social determinants of health, social needs. And then it also introduces the fact that there may be some other ancillary needs, in this example, legal needs that exist within that situation that can matter in helping the family. I also put it in because I think that it highlights the medical legal partnership model, which I think is really pertinent to the discussion around social determinants of health. Here at Akron Children's Hospital, we have a longstanding medical legal partnership that really started to be rooted within my own clinical work. And the concept here is that doctors and social workers and care teams and nurses have a certain role, and that a legal team also has a certain toolbox, a set of things that they can do to help families. And we refer often to our legal team to help remove legal barriers or address legal needs within the context of social determinants of health screening. So it might, the idea is social needs screening. See, I just did it. I will commonly say social determinants of health screening. And what I really mean is social needs screening. And it is a screen. We're talking about identifying something by asking a family some questions. That need becomes identified, and then we ask some more questions, and we respond to that in a conversational way to bring forward some other things. And our own journey in developing social determinants of health or social needs screening has very much involved the medical legal partnership model. So Jessica is going to talk a little bit later in her talk about some of the domains of social determinants of health as it relates to selection of different questions that you might ask. But I put up here some of the many common social determinants of health that we talk about. Sorry, I didn't realize. I just realized that I was looking at a different screen. This is the slide that I was referring to just a minute ago, talking about social determinants of health being a broad term, social needs being the more immediate individual needs that patients have that come into our offices or health centers, and then the legal need being something even more specific than that. So in this example, the social determinant of health is food desert. The social need is that the family needs fresh produce. And the legal need is that the family needs to appeal so that their SNAP benefits can get adjusted appropriately. So here are some of the common social determinants of health, and there are more than this. This is just kind of one of the lists that I use when I'm talking about this topic. But really the topic is quite broad. My co-chair likes to talk about the social determinants as being an ocean, and really loves to talk about how we don't need to boil the ocean, or we can't boil the ocean. And we're gonna have to take some of these pieces and do them one at a time. The next piece that I'm going to move into is talking about toxic stress. I recognize that toxic stress is an important component for us to talk about within the flow of information as we talk about social determinants. I also recognize that here in the state of Ohio, we have a wonderful national expert, our own Andy Garner. Dr. Garner is one of the past presidents of the Ohio chapter of the AAP, a very good AAP friend, and really an expert in this space. I hope that you have some opportunity at some point, if you haven't already, to hear a talk from Dr. Garner as it relates to toxic stress. And he wrote a couple of different papers, but I reference one here that kind of gives this model of an adversity. That adversity then leads to stress that builds up in a way that is different than just a moment of time stress. And that then has some changes that happen over time that lead to maladaptive behavior. And those behaviors then lead to poor health outcomes as adults. And what's nice here is if you read this schematic is that you can kind of see that there's different efforts and different interventions that can be put into place throughout each one of the steps of that process. I think that the group out of Harvard has a very good 2 minutes as it relates to talking about toxic stress. So I'm going to play for you now this short video that kind of goes over the concept of toxic stress and introduces you to that.
If it's possible to increase your volume, I'm not sure if we're hearing it very loud.
Okay, let me, give me a second. Let's see. Is it really faint?
It was.
It was? Okay, hold on a second. Let's see.
I can't hear it at all.
Let's see. Is that helpful?
It's a little better, still quiet, but better.
In severe situations, such as ongoing abuse and neglect, where there is no...
Haley, is that better? Is that better?
Yes, I think it's getting louder. Yes.
Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious, lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
All right. Did you catch the reference to early literacy promotion at the end? I really enjoyed that. I really like watching the last piece where the parents reading the book, because I think reading is one of those things. Reading with your kids is one of those things that can naturally kind of reduce some of those stressful events by creating good connection. So we'll move from talking about the accumulation of a chronic stress and its impacts and its neurobiological impacts on development into talking about adverse childhood experiences. ACEs, as it's commonly called, and I imagine that many of you on this call have heard about the adverse childhood experiences. I put the reference to the original paper. When I was teaching residents, I made sure that this was one of the sentinel papers that they always read and went back to. There's an incredible amount of literature that covers the impact of adverse childhood experiences. And I would summarize to say at the beginning of this that we still probably have not completely figured out how the evaluation and addressing of adverse childhood experiences is connected to social determinants, but they're very intricately woven. And so ACEs are those potentially traumatic childhood experiences that the research shows has incredible connections with the adverse outcomes of health in adulthood. So in the original paper, they looked at the presence of emotional, physical, or sexual abuse or neglect as a potential adverse childhood experience, exposure to domestic violence, caregiver substance abuse, caregiver mental health abuse, and parental separation or divorce, and an incarcerated family member as being highly connected to those adverse events throughout adulthood through the mechanisms that are kind of outlined in the framework to the right. So that adverse childhood experience leads to that neurodevelopmental change that changes the way that the child interacts, changes the way that they learn, changes their ability to develop some executive functioning, leads to poor and risky health behaviors, which then lead to disability, more increasing social problems, and early death. So it's important that we understand this concept, and a lot of what we're getting at in our screening in addressing these social determinant or social need issues relate to identifying what some of these adverse childhood experiences are. In the next session, again, Dr. Duffy's going to talk a little bit more about resilience and the role that resilience plays as an important factor in addressing, in promoting resilience within families as a way to mitigate the effects of social factors on health outcomes. So I'll spend some time now talking about what different social screening need systems are available, and there are a lot of them out there. This body of literature continues to grow. It has a nice exponential curve if you look at PubMed and look at how many articles per year are being published. There has been some great work by many people to establish these existing systems. They each have their own set of questions. They all cover about the same broad concepts, but have different emphasis in different domains, and they're of different length. They have different science behind the validity of the questions being incorporated into those tools. Some of them are available for the public. Some of them are available if you sign up and participate and agree to kind of continue to support those systems. Prepare, for example, is a national initiative around social determinants of health screening, and they ask that you give your email and participate and give some feedback as you begin to incorporate some of their tools, especially as you escalate those tools into your system. If you're in a larger healthcare system. And they have a differing ability to be integrated into different electronic healthcare systems. So I think that this review last year by Sokol is an excellent summary of what different tools are available for you to choose from. If you look throughout the country, about half of the practices right now are using what we call kind of like a homegrown model. They've come up with their own approach to social determinants of health or social needs screening. They've selected their own questions for different reasons. And we at Akron Children's really fit into that category. The rest of the percentage of utilization is a large portion by Seek, a large portion by iHelp, and a large portion by WeCare and Prepare. But so along our journey, I won't talk about this too much, but we wanted to select something that was practical, that would fit into our existing workflows, that could be manageable, and also something that we had resources around to be able to address. And again, Jessica's going to talk a lot more in the third session about what considerations that you need to take as a practice in order to make these things a real part of the work that you're doing. So I want to spend some time talking about the barriers to screening. Dr. McPherson, in his introduction, talked about my role in our primary care network. We have now 30 primary care practices. And when we started this work about 3 years ago, I was responsible mostly to train and to bring up the providers within those practices to the idea that we were going to take these 8 questions related to social needs into our workflow in a meaningful way. We're looking at, we screen all kids at well visits at least once a year for the kids less than 3, and then of course once a year for the kids older than 3. But it's important to identify that there are some real barriers to implementing some of these screening tools. One, provider knowledge and expertise in responding to a positive screen. I imagine, based on your interest that you're here today, that you might actually have some expertise that you are able to share with your practice or wherever you work around knowledge and expertise. But I want you to understand that while we're starting to incorporate some of these things into medical student education, this has not always been a pinnacle of areas of discussion within the medical curriculum. And so there may be some real true knowledge and expertise gaps that need some training as you implement these tools. The other thing is we want to be very careful that we're screening for things that we can actually do something about. And there is a really big problem to ask a question just to ask the question and leave a family when there's not a way to respond to that need. You don't always have to have all of the solutions, but having an understanding of what is available in your community. If you don't have any fill in the blank services in your particular area, whether that be because it's rural or because of a policy within your community, then you need to think about how that fits in. And I think that is one of the main reasons why you kind of see some of these hybrid models of questions being delivered to families. The mentality, isn't that so-and-so's job? I know on the call today, we have a lot of social workers and providers are sometimes kind of wanting to go out, and they put this in the literature even, isn't that social work's job? Isn't that the government's job? Isn't that the mayor's job? Isn't that the food bank's job? That mentality is real and is one of the pieces that you might meet some resistance around. Time is a big consideration. We built our screener to be completed within 2 minutes. And I spent some time in the design making sure that that was the amount of time that we could take. Taking 2 minutes within the time of a very busy practice is a big investment. And it's not just the 2 minutes, it's what's the conversation going to look like after that 2 minutes is over. This is sometimes the same thing that I see as we promote literacy within primary care, within the office visits. You have time for it, and it's important work, and whatever else that you were going to take time with, supplementing that activity, I think, goes a long way, again, in establishing a relationship, making sure that families understand that we really do care, that we are willing to spend time to talk about the things that matter for their outcomes. This is an important topic that deserves that amount of energy and time, but it's going to be something that people push back on, because there are a lot of other competing priorities within a very short amount of patient turnover. Maybe someday we can fix that through the way that we actually reimburse and get supported to take care of families, but that's coming, hopefully sooner than later. The cultural competency of providers is something to consider. Again, that goes along somewhat with the knowledge and expertise. The feeling that some of these problems are unsolvable. Housing has been going on as an issue for many, many decades, and it will not go away. And it is not easy to solve. So sometimes providers do feel like these are so difficult that I don't know why they kind of get this sentiment. It's hard to get into that space because I can't do anything about neighborhood violence, for example. Funding for support staff is something that you need to think about. So in your, as you think about putting together the process of screening and addressing these social needs, what does that staff look like, and how are you going to support that staff? Have you allocated resources in order to give them time to really work with families in a way that actually may help connect them meaningfully to existing community resources? The way you document and track these findings and your plans around them and what happens with them. And one thing that we are not great at looking at in the literature is how does that screening and addressing actually lead to improvement of results? And I think Dr. Duffy's got some more stuff to talk about on that question in just a little bit. Patient pushback is something that may be a barrier. Families sometimes might say, why are you asking me these questions? These are really personal questions. I don't want to answer them, or these questions are offensive to me, or something around maybe even their political response to that. Some people, when we first started rolling this out, got a little bit uncomfortable. And we've found that one way to mitigate that is to administer the screening to everybody and say to them, look, we care about what's going on in your life. We give this survey to everybody that comes through our door. And then also being very willing and comfortable with being, saying that they have the chance to not fill it out. It's okay that you don't fill this out. We're still going to take care of your child today. And then you move on. And lastly, as it connects to this conversation and discussion around abuse and neglect, is the parent's concern that a screen or a positive screen may result in a referral to Child Protective Services. This is a real thing that families are very worried about. Maybe if I answer yes, that I'm afraid that I'm going to be hurt, that you're going to call somebody and I'm going to lose my child. That, when it comes up, is part of the discussion and the empathy and the relationship that we started with. I'm going to move then last and finish up with talking about just the ethics and some of the considerations as it relates to development of screening. Similar to what we talked about with the half of the country developing a what fits and what fits with their needs within an organization approach, is the question of validity. And a lot of the questions, while well-intentioned, there are, in some cases, good ways to ask these questions. In other cases, there are no established valid ways to address some of these social determinant or social needs domains. So it's an area that we still need to do more research in. Ignored responses. What happens when people don't? What happens when people disclose a need to a provider and that provider does not address it? What are the impacts of that? What is the family going to think about that provider? What is what is going to happen in the future when other people try to help the family, when they've said something and it was never addressed within the course of that discussion? The lack of available community resources to address needs is certainly something. We do not have ubiquitous resources. I think Ohio is a great example of how some communities have more than other communities. What's the wraparound services going to look like? And is it robust enough to actually get to helping the family, which is what we want? One of the things that I think about a little bit is what are the downstream effects of the tracking, especially as we get this information into electronic health data systems, and some of that data is flowing back to an insurance provider. Are there going to be implications for that family in the future of a higher insurance premium if they do have a situation where they're going to be moving out of Medicaid insurance into a private payer model, or an employer paid for model, because they've been identified as having a social determinant, which has been found to be a influential factor in health outcomes, that puts them at increased social risk, that makes the insurance company think that they're going to cost them more money. What about patients who screen negative but have a need? I had a family that came in after they lost a child from gun violence in the last year, and the sibling, the list of questions were all no. I know that family has a social determinant need, but it was not captured in that disclosure. That's okay. I'm very comfortable with that. But if we set up our systems in a way that's assuming certain things, we have to be very careful with what happens with those patients that really do have a need that we're not addressing. We don't want to leave parents feeling targeted or inadequate in their parenting. I firmly believe that parenting is a tough sport. It's a messy situation. I'm a parent myself, and every day is not incredibly beautiful. Although there's some fantastic pieces of raising children, and our jobs as providers are to support those families, build them up, give them some reassurance that the things that they're doing are adequate for the life of their kid. And we never want to make them feel that we're singling them out or making them feel like they're not good enough. Are the screening questions and the interventions that we're providing actually what the family needs? Are they centered on the patient and the family? Some of this has to do with how you involve families in the discussions within your practice designs. So are you inviting them to the table as you're having discussions around what questions you're going to ask, or how you're going to have those conversations in the exam room, or how you're going to set up addressing those needs? Is it centered on the family and their needs? And does it help or make a difference? It is a big ethical question. Does this activity that we're all talking about today really matter for families? I think it does, but are we doing that's really what the literature is probably going to unfold with in the next 10 years. And Dr. Duffy is going to hopefully talk and touch base on a few of those, what next, and how does that make a difference? But I can tell you that the literature's lacking in that area, mostly because it's complicated. There's a lot of factors involved, and our investment in time and dollars is not where it needs to be, and not just within our own offices and systems, but within our priorities as a community and a society. We know that the United States is not investing in the social structures in a way that leads to improving health outcomes. All right, so with that, I'm going to finish up my slides, but I will open up the floor for discussion or questions. And I appreciate your attention.
Thank you, Dr. Davidson. We will go ahead and start with questions that might be in the chat box. The first is from Dr. Barb Galantowicz. Thanks for joining. And she had a question relating to the role of school health. What could that role be? I know she posted a couple of thoughts related to the interaction they have between children and caregivers and perhaps robust partnership opportunities.
Barb, could you introduce a little bit of your role? And I'm assuming that you're involved in school health, but that may help me answer your question.
Yes. Hi, how are you? I'm Barb Galanowitz. Yes and no. I actually used to do camps for children with medical and chronic illnesses. And we actually thought about doing that at some point, screening them, but then, the kids always came for free. So we really didn't have any resources to refer them to anybody except for the physician that would send them to us. But yes, in the last couple, obviously we didn't have camp, so I started getting a little bit more involved with schools, and actually trying to help a school who has nothing. They don't have a nurse, they don't have anybody, and in COVID, they needed some help. And so that's how I started thinking about school health and how much more they work so closely with the children and caregivers, at all times. And started looking into school health. And I know that different institutions have a more robust program than others. And if you have any insight into that, of how that works.
Sure. Well, thanks for the question. We have at Akron Children's a very robust and growing school health system, and are embedded in an incredible number of schools and school districts in our region. We haven't talked about what's like actual screening might look like in schools, but I think that you've highlighted a really important concept, which is communication with community providers, a network of care that relates to not a identification system or a flagging system, but a system of care where everything is integrated to the point where I know what's happening as the provider, because the school, I had a good relationship with that school nurse who knew that there was something important going on with this child or family. On the flip side, the school probably needs to know where those gaps are. This is a kid that I haven't seen in the office for over 3 years that hasn't had healthcare, that's behind. I think immunizations we have covered, but that it's kind of stops the back and forth communication stops there. But I think that you're kind of bringing up the question of can we build an integrated system of care where everybody who needs to know what's going on with that family or patient does know what's happening. What was the conversation around social determinants, and how could you follow that up in the school? School is an excellent setting for these kinds of things because school is where kids, well, in the past have gone regularly and have had a significant amount of contact. Dr. McPherson and the group, we had a discussion a little bit about, the lack of eyes on kids and kind of the concern that we have of cases of abuse or neglect where people are not seeing those kids and knowing some of the obvious consequences that are happening in some probably situations that are really under the radar right now because of the pandemic response. So having people who know and care about kids and know when there's something that's going wrong or going different is really important. I also thank you because I wanted to figure out how to fit in some of the good work that's happening in Akron related to schools. And this is not our school health, but it's, I think, an incredible story. And I'm sure that you've heard a little bit about this guy from Akron named LeBron James. And LeBron and his family foundation have invested in a public school that's right down the street from where I practice. And LeBron's school really does address social determinants in a meaningful way. I'll give you the example of how they do screening. And this is, I have no connection or relationship with I Promise school, but other than a lot of my patients go there, and I'm very impressed by the amount of care that their families get, the amount of value that those kids feel because of that system. But if a child walks into that school building and someone's greeting them and they have their head down and they're sad and they're upset, they are kindly approached and they have a conversation about what's going on and why that head is down before they move on into academics for that day. And there's an incredible amount of programming that's happening around, in terms of supporting the family, training. After school care is increased, the amount of contact time is increased. They have a medical legal partnership lawyer that works at the school, that hangs out on the playground, that's available for families. And the reason I bring that up is because of results. They're getting some incredible results out of that model. And I think addressing social determinants in the school setting might be an important place to invest some of our resources. So, thanks, Barbara, for bringing that up. And yes, schools have an incredible place to play in this. They don't have a formal place in our system to feed into the screening. But I think that what they're identifying is very real because they have a relationship.
Can I ask a follow-up question? So obviously it comes down to finances, and I think right now the schools are responsible to put nurses in their schools. So would it be something from the medical piece or institutions who might have a little bit more money to make that a priority? Or where do you advocate for that?
I don't have a perfect answer for that question because I think that people, our directors of school health are being quite fierce advocates in that and articulating kind of the value that they bring in the connections with those systems. So we haven't had a terribly big problem with that here. I'd be interested to open that question up to the rest of the audience if anybody has an idea for Barbara about how she could continue to advocate for more investment from the healthcare sector into schools.
And that's something we can also share with the rest of our presenters and our team internally to see if we have any ideas related to school health.
Well, thank you for your answer. Thank you.
This is Jessica with Dayton Children's. There's a couple other models out there. There's something called City Connects that's out of Boston that, I think the social determinants of health are actually the social determinants of education, right? It's the same challenge of outcomes. You're gonna, a lot of these challenges, if you don't have a healthy home, it's hard to do well in school or be healthy. So the City Connects model actually does some sort of screening in the schools and then works to connect families to resources or children to resources more in the academic setting. It's not always a healthcare provider, it's more of like a social work role. But I think there's different models out there that are really looking at the same idea around screening for social needs, but in the context of education. There's also a lot of community schools that are across the state and across the country. We have one that we partner with here in Dayton. Same idea. I have a staff person that just happens to work for Dayton Children's, and she does a lot of social connection and social needs connection for families in the school setting. So I think you're starting to see a lot of different models pop up, and whether or not it's embedding nurses in schools, this whole conversation around how the social determinants of health impact outcomes in general for children. I think both education and health are starting to look at this and it's starting those conversations then.
I wanted to say I'm a school psychologist, and so a lot of this is mental health related, and the Ohio Department of Education has actually done a really good job of pushing positive behavioral supports and trauma-informed learning. So I think most schools have been trained on that, and we have ACE screenings and other mental health assessments we give. And there's a lot of schools that partner with mental health counseling, so they'll come in and counsel kids, and either the board pays for it or Medicaid or health insurance. So we're working on it.
So I hate to cut off discussion, but out of the interest of making sure everyone has time for prepared presentations. I will encourage, if you have ideas, to share them in the chat, or feel free to send to us and we'll compile everything for afterwards. But I'm going to prepare us to pop back over for Dr. Duffy's presentation. So in terms of introductions, I'll go back to Dr. McPherson.
Thank you, Haley, and thank you very much, Dr. Joel Davidson, for that wonderful presentation, providing that great overview of social determinants of health, or as you also call it, social needs domain. I always appreciate the slide of the 3 kids watching the baseball game and the different levels of land that they're standing on in front of the different sizes of the fence and their different heights, and how that's a wonderful representation. So what needs to happen so all those 3 kids can enjoy the baseball game. I think that's a great summary of what we try and do when we discuss social determinants of health. And I also appreciated your section as well as barriers to screening, causing me to think about, okay, in my clinics, what are our barriers? What can we do differently? How can we implement something like this? So thank you for that discussion. So moving on to our next presenter, I am pleased to introduce to the group Dr. Jim Duffy. He is a pediatrician and a child psychiatrist with clinical appointments at the Boone Schaff School of Medicine in Dayton. He is the chair of the executive committee of the Council of Community Pediatrics for the American Academy of Pediatrics, and the chair of the Medical Advisory Council for the Program for Children with Medical Handicaps at the Ohio Department of Health. He is a lead author of the recent AAP policy on child poverty in the US, early childhood home visiting, and a forthcoming policy on trauma-informed care in child health systems. In 2006, he received the Healthcare Delivery Award from the Academic Pediatric Association for founding a comprehensive pediatric medical home in a historically under-resourced community in Springfield, Ohio. He was recognized in 2008 by the Ohio chapter of the AAP as Outstanding Pediatrician of the Year, and in 2014 with the William H. Cotton Physician Advocacy Award. Retired from clinical practice, he lives with his wife on a small farm in Clark County, tending chickens, honeybees, and a maple grove. Those are just a few of his accomplishments and a few of descriptions of the impact that he has had in our community. So we're very pleased that he has taken some time to share with us his thoughts. And Dr. Duffy, I turn it over to you.
Thank you, Dr. McPherson. That was more than gracious. Thank you very much. Haley, I think I'm going to try to share my screen, but
Sounds
we'll
good.
see whether that works.
Yep, we're just
I don't
ready
have,
to...
I just was, all right, as just was mentioned, I live in a rural area, and unfortunately we don't have broadband, and so it may work, it may not. Oh no, did not work. Maybe that. Yep. How does that look to you?
Looks good. I think we're seeing the whole presentation. So, and now.
Okay. All right. Is that you see the title slide?
I see the title slide, but I also see the full PowerPoint.
I don't know how to do that, but.
I don't know if you want to click on from beginning. That might.
I did. How about now?
So we can see the slides. It keeps trying to switch over to the presenter view.
All right. Well,
We can work with this.
Let's use
if you're
yours then.
comfortable, or try.
Yeah. Let's use yours. I'll pull out of mine and you use yours.
Okay. I'll just make mine full screen. Okay, if that looks all right. Oh, it went from just a second. I will pop all the way down. This is the speed version. There you go.
Okay, so let me address a little bit. Joel turned quite a bit of material over to me and expected me to prove the case. What I'll say is that this represents the conundrum of public health interventions, and that is that the outcomes, the preferred outcomes, are things that don't happen, so they're difficult to measure. And there are a lot of confounders in this kind of work, and so we need some more time to develop the evidence base. And a lot of the programs, even that I'm going to talk about now, are in process of evaluation. And I'll kind of identify that as we go along. Next slide, please. And that's my disclaimer. Next slide. Now I'll be trying to make the connection, since this series of presentations has been related to child maltreatment and child abuse, and started out with sentinel fractures and so forth. In this case, what I'd like to do is make the connection between poverty and child maltreatment. A problem right away is to say that child abuse or child maltreatment doesn't just exist among poorer families. It exists in all socioeconomic groups. But we have some peculiarities regarding child maltreatment and poverty that we're going to emphasize today. What I'd like to do is try to answer the question, can the risk of child maltreatment be reduced by addressing social risk factors? That's pretty straightforward. That's why we're saying that we would screen and make those linkages to services in the community in order to stabilize families and to reduce the risk to children. And then, are there strategies that can be applied to pediatric practice to reduce child maltreatment? And then, what are some community-based strategies that have been have been being employed in Ohio? And what that means is we're talking a little bit about the linkage between poverty and child maltreatment, and then saying that there are interpersonal ways of protecting children, but there are also community-based strategies. Now, there may also be intrapersonal risk factors for each child, and we're not going to talk about that today in particular. That was, Joel talked about that a little bit, but we're not going to talk about intrapersonal, but interpersonal, particularly clinically based, and then community-based. Next slide, please. And we're going to start out by trying to make that linkage between poverty and child maltreatment. Next slide. And here's the relative risk. Overall, in every sort of maltreatment, the incidence is about 6 times higher for children in low-income families. We have to examine why that is and what sort of treatment. But the incidence of physical abuse is about 3 times higher, but neglect is almost 9 times higher. As you can see on the slide, I don't need to read the whole thing though, but that there's a list of risk factors that are associated with poverty. And the conclusion of this of the pediatric research, and I think in the pediatric literature, is that routine screening for social determinants of health and referral to services should be an urgent priority within primary care. Next slide, please. Lots of words on the slide. Some slides have a lot of words in them. I think I provide the detail because I hope that the PDF of the presentation will be available to everybody later on, so you can go back and look at it. So how does it happen? Poverty results in material hardship, financial stress, And if you look at the expanded ACEs, we talk about the original adverse childhood events study. It was all intrafamilial. It was there was nothing about community stress or social stress. It was all intrafamilial. It was child abuse or sexual abuse, violence, exposure to intimate partner violence, a variety of things, parental mental illness, parental incarceration, loss of a parent. These were all intrafamilial. The expanded version of ACEs, though, really number one early childhood adverse event or experience is exposure to financial stress or poverty. That's the number one. And all the studies that I've looked at. The associated hardships may increase unintentional injuries that may be presumed to be intentional. And that's one of the reasons why I think that there's an increased number of referrals for low-income families, because essentially we're talking about neighborhood effects, housing insecurity, unsafe neighborhoods, environmental hazards. All those things occur in low-income neighborhoods, and those things are risk factors for injuries. And unfortunately, those injuries sometimes can be presumed to be intentional, and referral is made. And in particular for neglect, parental inability to supply basic needs can be confused with neglect and lead to removal, and often does. And I think that may be one of the reasons why we see a disparity of African-American children that are in foster care, for instance, in Ohio, not because they're African-American, but because they come from poor families, because African-American families are generally higher rate of poverty than white families. Now, drilling down a little bit, it's very interesting. Each percentage of state level unemployment is associated with an increase in child maltreatment by about a half a child per 1,000 children. And that's pretty amazing. And so what we have now is, and I remember reading a study a few years ago from the Kempton Institute that there was a direct positive relationship between unemployment and sexual abuse. And that means that men are home, they're depressed, they're drinking, and they're more likely to abuse their children. I say men, it can be mothers as well, of course, but I think we have to understand this child abuse in some degree as a male social disorder. Higher income inequality, is to take it from a little bit different standpoint. Communities and neighborhoods that have a high inequality, wealth inequality, are significantly associated with higher county level rates of child maltreatment. So inequality, not just poverty, but inequality. Some people in the community have a very high income, some people have a low income. Those communities have a higher rate of child maltreatment. And in this study in pediatrics in 2014, the statement was made. And when I've actually quoted people, I put it in italics. More equal societies, states, and communities have fewer health and social problems than less equal. It's common sense in a sense, but I think it probably doesn't integrate into policy very well. Next slide, please. Money matters. Straightforward, money matters. We find that, and this is a quote from this study from Child and Youth Service Review from 2017. We find that increases in the minimum wage lead to a decline in overall child maltreatment reports, particularly neglect reports. Specifically, a $1 increase in the minimum wage implies a statistically significant 9.6% decline in neglect reports. That's pretty amazing. I think many of you would agree with that. The reduction is especially strong for neglect among young and school-aged children, and that makes sense. If you think back to the other slide, that sometimes the lack of the ability of parents to provide food and housing, shelter, healthcare is sometimes thought of as neglect, and so the children are removed. I would also say, we do a lot of screening and we do a lot of screening in pediatrics. I've had some conversations recently with very wise people. People think about this more deeply than I. We say that maybe in the future we should be asking families about eligibility in a different way. Are you eligible for SSI? Are you maximizing your earned income tax credit? And these are ways that we can actually put more money into the hands of families. I don't know whether the pediatricians have the expertise to do that, but I've often thought, and years ago tried to put financial advisors in the clinic, in the FQHC I was working in. Next slide, please. So place matters as well, and this is one of my favorite slides. On your left is a red line map from the 1930s, looking at Dayton, Ohio. And you see the little curve, the little S curve, so you can kind of orient yourself where things are. Jessica and I saw Dr. Doobie on the list as well. You recognize where the red is on the red lining. The red is where banks were not allowed to invest in, or they thought the neighborhoods were poor risks for investment as far back as during the Jim Crow age, before mid-50s. And the red areas were the places where there was no investment, and the green areas were places where where there was heavy investment. If you look over on your right, that's what's called an opportunity map from the Kirwan Institute at Ohio State. And interestingly enough, the white areas are very, very low opportunities. They have low opportunity scores. And if you look very quickly, the convex area of the S curve, the white area very, very obviously overlaps with the red area. So from 80 to 100 years ago, lack of investment by banks in that area led to a food desert that we'll talk about. And if you look at the rates of illnesses, that's an area of Dayton, Ohio that has a high rate of obesity and hypertension, strokes, shorter lives. If you look around on the other side where it was green on the redlining map, well, that's blue. I mean, there's a very high levels, and that's where a lot of the doctors at Dayton Children's live, and it's Oakwood and those areas. And as a matter of fact, the green circles are where white people live. So white people live in all the green areas, all the green circles. And what it means to me, and when we talk about redlining, we think about it, or we may be tempted to think about it as historical reality. It's not a historical reality at all. It's a present reality, because the opportunities that are currently available in places that were redlined 80 to 100 years ago keep kids in poverty and worsen their health outcomes. Next slide, please. And these are some of the other neighborhood effects. Neighborhood poverty is related to neglect. We've made that theme already, regardless of parent income. But affluent neighborhoods reduce physical needs neglect for low-income parents. And you can imagine that if an affluent neighborhood, the tax base is high enough that they have decent schools, they have places to play, they have sidewalks, their houses don't have lead or asbestos, and so the affluent neighborhoods reduce the physical needs. They have stores, they have Kroger's rather than little corner 7-Elevens that sell food. So other forms of maltreatment are unchanged in lower poverty neighborhoods. So it's really neglect that we're talking about. Interesting. All right, next slide, please. Race matters, but as I mentioned before, it's because of different rates of poverty. Strong positive association between child maltreatment and poverty in all race ethnic groups. So it's race it's not race, it's poverty. Yeah, obviously, race is a social construct, and it's pointed out very, very easily by looking at poverty, because it's a social construct. Because of the social disparity, because of the wealth disparities, the inequities are driven by the disparities. The black-white disproportionality largely driven by black-white poverty rates. Next slide, please. There's also a great concern of the criminalization of poverty. And we see that all the time. And this happened, I put this in here because we're not entirely aware of how poor some parts of our state and some parts of our country really is. This was the report of the Special Rapporteur on Extreme Poverty and Human Rights on his mission to the United States of America, as in 1917. And he traveled from California to the Southwest, and then down to the South and up through Appalachia. And his reports and conclusions were damning. The UN's Poverty and Human Rights Special Rapporteur finds U.S. policies reward wealthy and punish the poor. And one of his recommendations was to decriminalize being poor. And the reason I put this in, because mass incarceration and imprisoning the poor strongly affects family integrity and hence the children's lives within particularly poor areas. Another recommendation was to acknowledge the damaging consequences of extreme inequality, and that he picked up on the same thing that we talked about a minute ago on the other slide about wealth inequities, and recommended that we recognize a right to health care for all people. Punishing the poor, punishing and imprisoning the poor is the distinctly American response to poverty in the 21st century. It's a bit of a reach, but we have to think sort of broadly about systems and complex systems, and try to figure out where we can find a leverage point to change the operation of the whole system. And it may be that bail reform or decreasing the criminalization of homeless people, or providing support for families instead of putting their kids in foster care, are ways that we might be able to find that leverage point and change the operation of the system so children will be healthier. Next slide, please. I want to mention just a minute ago, I'm not going to go through this in great detail, but we know that the opioid epidemic is a huge problem in the United States. And I think there's a recent book called The Deaths of Despair, and others that really talk about how the opioid epidemic has affected Ohio in particular, and other places in the United States, but certainly in Appalachian, Ohio. The opioids have created a huge problem for children. And I put this in here really is because in a minute I'll talk about a protective factor of the child-parent relationship, and some of the deeply disturbing effects of maternal and paternal opioid use are extended separation from parents, maternal deprivation, and impaired parenting and attachment. Next slide, please. This is the scope of the problem. It's a little bit old now, but some of these data are difficult to keep up to date. But in 2015, 28% of foster placements were in the context of parental substance use disorder. And the children who are placed in foster care are, because of parental SUD, are in care longer because of the frequency of relapse and the need for long-term case management. At the same time, state funding fell by 21% during 2009 to 2016. Next slide, please. And here's just a graphic to show you that that statewide now, the number of children that are placed in foster care because of opioid use disorder is about 50%. And the number of Ohioans projected to be in foster care by 2020, that's this year, is about 20,000 children. Next slide, please. We have to think also broadly about how the system is working. Foster placements are up 28% in the past 5 years. That was up to 2018. But 1 in 7 caseworkers quit in 2016 and 2017, and more than half the children's service workers have PTSD. That's a huge problem. That's a tremendous problem, and I think as primary care doctors and social workers and psychologists, to care for our, we have a tendency to be impatient when we make a referral, and particularly angry when it's not being taken up by the children's services worker. And why are these children still in danger? This is some of the reason, and it's some of the reason that we need to advocate for either locally with DGFS or on the state level. Next slide, please. Okay, so now, as I mentioned before, I'd sort of make a link of the poverty and child maltreatment. That part of this is a little bit over anyway. Now we're going to talk about both risk factors and protective factors related to interpersonal relationships. And I'm going to frame that in a primary care setting. What are the issues about relational health in primary care? Every few years, I've seen an article. I was in practice for over 40 years. Every few years there was an article that said redesigning primary care, and they're all good articles and they have great ideas. I think the next wave is going to be that our job as primary care clinicians is to promote relational health, particularly in the 0 to 3 or 0 to 5 group. Next slide. So what is it? What's relational health? And John Bowlby wrote the book on attachment, and he actually did his research during the Second World War on internally displaced children, which is a very interesting circumstance since we have a lot of internally displaced children now. Emotional bonds are basic for survival, and this is something that's what we call serve and return. That it's not just unilateral. It's not bonding that the parent bonds with the child. It's an attachment, which is bilateral, that the child relates with the parent interrelates with the child, a caregiver, and they develop that secure attachment that allows the child eventually to move into the world and become curious and explore the environment in a way that's self-confident. From the psychiatric standpoint, or the depth psychology, they talk about internalizing the parent so that they can, by the time they're 2 or 3 and or 2.5, they're able to carry around this idea of that secure relationship with them, and they can draw from that idea of that secure relationship that's internalized, so that they have that sense of integrity and are able to explore the environment. What happens when that doesn't occur? Well, you have both internalizing and externalizing attachment patterns, and worse, the ambivalent, disorganized attachment. And honestly, that's the worst situation. I've certainly seen a lot of kids within the opioid epidemic who are in foster care that have that kind of disorganized attachment. Next slide, please. Just a graphic that reminds you what it means. Cervical security is a strategy, a primary care strategy that we don't have much in Ohio. I'm not certain, but the graphic is really great. That this looks like you know, what we see in the reception area of a 15-month-old baby, for instance, that moves out from the parent and kind of creates this little star around the parent, go out and explore and then turn around and make sure the parent's there and then run back and hug its knee and then goes out again and tries it out and maybe falls and cries for a minute and then goes back and it goes back to the secure base. That's the paradigm that for the circle of security and the secure attachment. And of course, when our kids were young, we read Pooh every night. And so this is Pooh and Piglet. And Piglet sidled up to Pooh from behind. Pooh, he whispered. Yes, Piglet. Nothing, said Piglet, taking Pooh's paw. I just wanted to be sure of you. That's a secure attachment. Next slide, please. That's what we're talking about. So that idea of resilience and relational health, and this is where it came back to some of the earlier slides, and I anticipated this one. The most important and frequent commonality of children who succeed is that they have at least one stable and committed relationship with a supportive parent, caregiver, or other adult. This is the mitigating factor. This is what mitigates. This is what moves toxic stress to tolerable stress, and then also maybe there's one that's a positive stress, because you know not all stress is bad. Stress can be positive. Given a talk on Zoom is stressful, but I hope it's positive. It's certainly tolerable. It's not toxic. But this is what changes for children if they're in a potentially traumatic event and they have a secure relationship. They're much more likely to be able to emerge from that potentially traumatic event without long-term toxic stress. Next slide, please. And I don't have to go through this. This is sort of a little bit more academic, but we'd like to say that resilience is any of these things. It can be an ability, a process, a result, or an activity. But the bottom line is that it transforms toxic stress to tolerable stress. Next slide, please. And once again, the foundations of resilience: at least one stable, caring, and supportive relationship, and a sense of self-efficacy, which is probably that internalized sense of security in the presence of the parent-child relationship, or the caregiver-child relationship. There are other things here that I think are pretty interesting. Solid grounding in cultural traditions. The sort of I've wondered how much of a cultural tradition affects a child's self-esteem. I think it's substantial. Strong executive function, self-regulation. Those are frontal lobe activities that are affected by toxic stress, and I think it rolls us over into the intrapersonal protective factors that really are beyond the scope of this talk. So next slide, please. For the clinical, for clinicians and for all of us, it's important to realize that we can learn resilience. Important relationship. In fact, I'm going to talk a lot about 2 generational interventions in a couple of minutes, and one of the ideas here is that as clinicians, we need to start thinking about more effectively the maternal child or the parent child or caregiver child dyad, and can we, as a matter of fact, help that caregiver to help the child develop resilience? I think that's an important, and some of the studies have been done with young mothers, for instance, with 2 generational teen mothers who are seen by the same person, the same, and I know that I have a friend at Brown University that's developed a really vigorous, robust program that brings in children and the adolescent, babies and adolescents, and works on that, work directly with that dyad. Next slide, please. I don't know whether I'll do all these. The next three slides really are about hippocampal volume growth. The hippocampus is a part of the brain that's related to learning, long-term memory particularly. And it's damaged by toxic stress. As a matter of fact, if some MRI studies of children in long-term foster care, for instance, show abnormalities in the growth of the hippocampus in the brain, smaller hippocampi, essentially. And some of them have larger amygdalas, which is related to the flight, fight, freeze, affiliate system, stress system of the body, along with changes in the frontal lobe related to toxic stress and the effect on impulse control and attention, executive functions. But in all these three studies, caregiver support improved hippocampal growth. So 127 children studied longitudinally. There was significant effect of early childhood maternal support on hippocampal growth volume. That's amazing. Next slide, please. In this one, there were a cohort was followed for 20 years, and there was a parental there's association between parental nurturance and memory development, and environmental stimulation and language development. Once again, it supports the concept of maternal buffering and stress hormone effects on hippocampal development. So here's sort of MRI evidence of that ability of a buffering effect of a secure attachment with a caregiver. Next slide, please. Here's one that looked at a little bit different, but it had to do with, it's not an MRI study now, but it had to do with parental interactions and expectations for achievement in school attendance. When those three things were available and were present, the average reading and math rankings increased from a low 30% to approximately 70% across quintiles. This was from the U.S. Early Childhood Longitudinal Birth Cohort Study. Next slide, please. But we'll get back to school in a minute and talk about, but I wanted to sort of reflect back for just a second. This is kind of a parenthesis. ACEs and academic achievement. This is pretty amazing. We were talking about schools, and you were asked about schools a minute ago. But with 3 or 4 ACEs, 3 or 4 more ACEs, children are three times more likely to fail, and 5 times more likely to have severe attendance problems, 6 times more likely to have severe behavioral problems. I'm reading all this because it's important. 4 times more likely to self-report poor health. And what this does is helps us understand the school to prison pipeline, because we have a first grader with unruly behavior at risk for multiple suspensions, poor reading ability, decreased graduation, criminalizations of youth behavior, and early incarceration. Now, it's not going to be every time, but we're talking about screening. And there was kind of a debunked joke a while back, but the idea is correct. Not a joke. It's not a laughing joke, but it was said for a while that the Ohio Department of Corrections could predict how many cells they would need in their prisons by understanding the results of the 3rd grade achievement tests. It's debunked. It's not true, and yet sort of the concept is an important one for us to consider. Next slide, please. So how do we do it and promote relational health and primary care? We promote a safe, stable, nurturing relationship and environment. And that phrase comes from the CDC and their work on prevention of child abuse. We engage, serve, and return, and we help parents recognize temperament variations. By the way, when 15 years ago or so, I developed a you used a temperament scale, and in the midst of the screening in early childhood, before we started doing the ages and stages, I did a temperament screen at 2 to 4 months, and I'd ask the parent to fill out a temperament scale, and then eventually in the conversation I'd ask the parent to fill it out for themselves, and then we talk about the temperament match or mismatch, and from that we could really predict how we would go forward. We developed some insight in how we would go forward to help that dyad. The caveat here is the psychoeducation, the parent education, that whole range of things is insufficient. We have to improve the attachment and relational health to buffer the toxic stress. Next slide, please. And one of the ways that Dr. Davidson already brought this up, one of the ways that we can do that is through early childhood literacy promotion and Reach Out and Read or some other program, and you can see the attachment going on right now, and using the books in full measure, using the Reach Out and Read in full measure to promote that interaction during the examination, to have parents show how much books are important and how they can read together. I would say also one of the things that we've thought about sort of looking at interventions would be also to screen parents for literacy level, because we know a lot of parents in low-income neighborhoods, maybe even up to 25% are below below a grade level of third grade, and at least 50% or so are below sixth grade reading level. So we have to be aware of our literature and be aware of how we're approaching folks. And if we can engage those parents in a literacy activity along with the children, then we're helping out both generations. Next slide, please. And so one of the things that is important to realize is that with Reach Out and Read, these are the outcomes. I think it was the Johns Hopkins School of Public Health, the Bloomberg School of Public Health, I think, called Early Childhood Literacy. Reach Out and Read have as this kind of evaluation that children scored higher on school readiness assessments by about 6 months at least. And parents are up to 4 times as likely to read with their children, and they're more likely to spend time with the children. So this is really something that's powerful, that I think all primary care offices should be engaged in early childhood literacy promotion. I think there's probably 2 or 3 things that are apart from our physical examination, developmental assessment, that are most important for primary care. Obviously, the first is vaccines. Probably the second, before anything else, is early childhood literacy promotion. And the third is relationship enhancement, attention to relational health. It's a little bit unconventional list. You may disagree with it, but that's where I am now. Next slide, please. I think we're about ready to move to. Oh yeah, I just wanted to mention maternal depression. The effect of poverty on maternal depression. At least half of those mothers who are living at or below the federal poverty level have depression, and many have severe depression. In fact, poverty as a confounding factor will increase the severity of depression. 11% in poverty experience severe depression compared to 7% overall, and 25% of poor and near poor have postpartum depression. But here's the rub: low-income mothers are less likely to seek treatment, even though we know that effective treatment of depression is successful in a large number and a large percentage of mothers. Next slide, please. Now, how does depression affect the relationship? It disturbs attachment, it reduces responsiveness, decreases warmth and nurturing. Also, just feeds back on itself. Depressed mothers are difficult to activate by children. They increase have difficulties with consistent limits and routines, discipline, and all the other things that we'd like to do during well child care. Reduces the likelihood of those being followed through with. Next slide, please. As I mentioned, it has a bidirectional effect. Food insecurity and substandard housing may contribute to chronic stress and depression. And depression obviously makes it more coping more difficult, so it makes it much more likely that there is substandard housing and food insecurity. But here's the link to family violence. Both inter-partner violence and child abuse are more common, as well as substance abuse, as well as social isolation, is more common with poverty, families in poverty. And again, this really belongs to what I was talking about a minute ago, that 80% improve with treatment, but only about 15% seek and receive care. So here we have another screening opportunity that affects children, screened for maternal depression. Next slide, please. Okay, so we're going to move in the last 10 minutes or so. We'll move into, I don't have 10 minutes, but I'm going to move through this anyway. Community strategies. Next slide. Let's go quickly. Differential response is a national strategy, but it's also an Ohio strategy. In Ohio, about 10 years ago, there was a pilot program that's called Alternative Response. Essentially, the idea was to develop two different pathways when there was a children's service referral, because most of the referrals do not need a court-ordered solution or adversarial response. It needed certain services. So when I practiced in Virginia, when I was on the faculty there, the Commonwealth has a petition called Child in Need of Services, or a CHINS petition. They don't have such a thing in Ohio, but they do have this shared pathways, two pathways. Once the referral has been made, then a child goes into one of the other pathways, either an investigatory or a non-investigatory pathway. Next slide, please. And the services in the non-investigatory pathway include these: concrete services, food, clothing, utility payment. You know, it doesn't make much sense for a child to go into foster care, be cared for, and all the expenses that are involved in foster care if all the family needs is a refrigerator. So sometimes the utility payment is what's needed. Sometimes it's just plain parental support because of mental health problems or substance abuse treatment. It may activate home visiting, other two-generation, all interventions, and then there's a group of people, for instance, with immigrants or children with medical complexity, the deaf community. Those are special circumstances that may be activated by going down, if there's a referral, activating by go down the non-investigatory pathway. Next slide. Here's just a map of the differential response implementation. Ohio there is essentially regional or county level implementation. I talked with the director of that program last week, and she said that there will be some form of revision of the differential response since the outcomes haven't been as robust as they would like, partly because different counties administer the program in different ways, because we have this kind of strange system in Ohio in which there's 88 counties and over 100 health districts, and each county has the ability to administer a program in the way that they want. So there's not a unified way of administering the program, and so some of the data are difficult to obtain. Next slide. What we do know is that in the national evaluation, that child safety is not compromised. Recidivism or referrals to children's services were decreased slightly in Ohio using the non-investigatory pathway. families and CPS workers reported greater satisfaction and willingness to participate. There is some indication of at least revenue neutral or cost effectiveness. Or if it were, I think, applied with fidelity, it would probably be cost effective, since foster care costs so much, and it hurts kids. You know, I think we have to do what's right. So next slide. We'll go through this fairly quickly. Two generational intervention. D.W. Winnicott was a child psychiatrist, actually a pediatrician who became a child psychiatrist, who said in the early 60s, there's no such thing as a baby. Without maternal care, one would find no infant. So that's sort of an old-fashioned way of saying it, but what we need to understand is that mitigating relationship that mitigates the effects or buffers the effect of toxic stress requires two. It's bilateral. Next slide. Home visiting has a very strong history with poverty reduction, improving maternal health and child health, perinatal health outcomes, improves relational health, family functioning. What's not on here is that at least with nurse-family partnership, there are data that say that early childhood home visiting reduces referrals to children's services, both on abuse or neglect. Next slide, please. Next slide. Here's one that's an Ohio program. It's called Moving Beyond Depression, and very interestingly enough, it's in southwestern Ohio near Cincinnati. And these the home visitors go out in pairs. They have a person who's working. Now that's Ohio Start. Previous slide, please. So basically, there's identification of a dyad at risk. The mother is depressed, and the home visitors go out in pairs, one to do developmental stimulation for the child, and the other to do in-home cognitive behavioral therapy for the mother. It's an amazingly strong concept. Next slide. And this is the Ohio START program. We talked about the maternal depression risk factor. This is an opioid program, sobriety, treatment, and reducing trauma. And you can see that actually this is a 2018 map. It's in more counties now, but this is a intensive, comprehensive, interdisciplinary, multi-generational home visiting program that helps kids stay with families. And if placement is necessary, that the time of out of home is shorter. This program is being evaluated nationally. Next slide, please. We're getting to the end here, so this is something that's really dear to me. As I think Jessica talked a minute ago about the elementary school that Dayton Children's is connected with, and that's the picture on the lower right. It's Kaiser Elementary. It's very close to Dayton Children's. One of the many ways that Dayton Children's is involved with the local community. Joanie Forces for Children is a Cincinnati group, and there are community members and Cincinnati Children's Hospital working on building resilience and fighting childhood adversity. And then in the center is an amazing program at Kelly Kelleher and others are involved with the Nationwide Children's Healthy Neighborhoods and Healthy Families. They actually take local housing stock and renovate the housing stock, but the same people move in. It's not, they don't gentrify it. And they're also involved with the schools and the churches and the food banks. And the next slide, please. And that's basically where we'll end. This is an example of a program that links the Wexner Medical Center and Department of Family Medicine with one of the largest food banks in Central Ohio. And if a person comes into the medical center and identifies the need for fresh fruits and vegetables, it actually is, they enter into EPIC, and that EPIC, that part of EPIC is shared with the Mid-Ohio Food Bank, and the patients go over to the food bank to get the food. Next slide, please. And here's where I'm going to hand it off to Jessica, because this is a program that she's been involved with in Dayton, which is a partnership. Well, it's Gem City Market. It's a co-op in that same area that I showed you earlier that was redlined, and it's a food desert. And the community got together and developed a plan for a co-op. And the person on your right side in the red sweater is the CEO of Children's Hospital, and so this is an amazing kind of effort that may actually have a health clinic embedded at some point, but it's designed to provide healthy food to that food desert in West and Northwest Dayton, to make nutrition education and culturally appropriate cooking instruction available to children and families. Next slide. I think that's probably the last. Yep. So Jessica, I'm handing it off to you, and you can tell us a little bit more about the Gem City Market. I'd be glad. I didn't leave much time for questions. So after Jessica talks, if some of you have questions you'd like to email me, I'd be glad to answer them or discuss them later on and try to respond to your questions. I'm sorry I took a few minutes of your time, Jessica.
Thank you, Dr. Duffy. We have said we'll capture questions if anyone has any, and definitely forward them for answers. So I will turn over for our introduction for Jessica to back to Dr. McPherson.
Thank you, Haley, and a big thank you to Dr. Duffy and his wonderful presentation regarding the social determinants of health and his insights into poverty and the other issues that make it more difficult for us to really ensure and work towards happy, healthy children all across our nation and specifically here in Ohio. So thank you for that presentation. I'd like to dive into our last discussion for this afternoon. Jessica Sanders, she is the Director of Community Engagement and the co-founder of the Center for Community Health and Advocacy at Dayton Children's Hospital. She's responsible for Dayton Children's community health programming, including the Dayton Asthma Alliance and the Family Resource Connection, a program that screens for social needs of patients. She is also the project manager for the Dayton Children's Regional Pediatric Health Assessment, which is used to set children's health and safety agenda for the hospital. She holds a Bachelor's of Arts degree in Public Relations and a Master's in Public Administration, both from the University of Dayton. She was named by Dayton Business Journal in 2012 as one of their 40 under 40 top young professionals in the Dayton region. She serves as adjunct faculty at both Wright State University and University of Dayton. She is a past president of the Junior League of Dayton and currently serves on multiple boards, including the Board of Governors for Leadership, Dayton, and the Five Rivers Metro Parks Commission. So without further ado, we are pleased to have Jessica Saunders here this afternoon, and please take it away.
Thank you. Haley, I'll just have you, for the sake of time, advance slides if you don't mind. Great. So thank you to Dr. Duffy and Dr. Davidson. I think it's overwhelming when you start to hear about the social determinants of health, ACEs, everything that we've talked about. And so I hope in the last couple minutes here, I can take the overwhelming boil the ocean concept and really just think about boiling a pot of water and think about just a couple key steps that maybe your practice or your organization can take to start really thinking through how you might screen for social needs and start to just chip away at some of these challenges that families might be facing. The way I think about it is the hierarchy of needs. And if a mom doesn't have food on the table, how can she even think about reading to her child? And so really just thinking about what are those social needs, those basic needs that we might be able to help families with. So if you go to the next slide, I think the first thing is, when you're trying to think about, how do you take everything you learned today back to your organization? It's really about defining your why. And I have the picture here of this little guy, and he has an empty bowl, and I don't want him to have that empty bowl. And so I think, hopefully after hearing Dr. Davidson and Dr. Duffy, it's really solidified your understanding of why the social determinants of health and addressing them really are important to your practice. And I think I'm going to echo what Dr. Davidson said about just really thinking about starting with who matters or what matters, and having that why. So as you might take a leadership role in your organization or in your practice, you can really share with others why this work matters, and to start there, because as I go through the next couple of slides, it still will be a little overwhelming, but I think if you can just recenter back on the why while you're doing this work, it's important. And so the first question that you really want to ask in your practice is, who will you screen? And so, you might, and you've heard a couple of examples. So you might just screen all kids that are in for a well child visit, or maybe you'll screen all sick appointments or all appointments in general. So really you need to define who will you screen. And it's not that you want to screen kids that are only from a certain neighborhood or only with a certain insurance. That is not what I'm saying. But you do want to think about what's the cadence that you're going to be able to screen in that your practice can actually handle. And so maybe it's every visit, it's every yearly visit. Those are the things that you want to think about. And then you also want to think about your unique population where your organization is. So, first of all, you don't want to have screening fatigue, and we know that is real, and there's a lot of screenings that we conduct, but also the unique population that may have special needs that you hadn't thought about. So you want to make sure you're treating all your patients equally, but thinking about, rural, urban, suburban, maybe there's different sets of needs, and that might dictate who you screen when you start screening. So the next slide. The other challenge is, what are you going to screen for? And I know that you got to see all the questions that are out there to ask about screening. And so it's really important that you start doing a little thought on what are the social needs that might be most prevalent in your practice population. The easy place to start is to screen for food. There's some really good USDA questions out there that are common. It is, I'll say, maybe a low-hanging fruit, no pun intended, but really start thinking about maybe some initial data collection before you start officially screening to find out about what are the needs in your patient population. And here again, think about if you're in a rural, urban, or suburban area. So if you're in an area in Dayton, we know we have a lot of food deserts, so food needs are higher. Maybe you know that there's transportation challenges in a rural area. So, you don't have to screen for everything, but you want to be thoughtful about your patient population and what makes sense to screen for. Then you really need to know what community resources are even available. And as Dr. Davidson and Dr. Duffy mentioned, you don't want to screen for the sake of screening. That really gets into a lot of ethical considerations. So you need to know that there's resources out there. And it's not a matter that you individually have to do all of this research. Find out who's in the know in your practice, who knows a lot about community resources, and really leverage them in this process. So do you have food banks? Do you have an after-school program for kids? Do you have transportation options for families? Because if you don't have a place to refer families, you may not want to screen for those specific things. But please leverage your own staff because they know a lot. The other thing is there's tools such as Aunt Bertha. That is something, it's auntbertha.org, I believe. You can check for resources and you type in your zip code and you can see all the community resources that are there. Or look at your United Way 211. There's a lot of lists of resources out there, so you don't have to reinvent the wheel, but you really need to understand what resources are in your individual communities. You might be surprised at what a quick Google search gets you. And then there might be some natural needs questions or natural questions that you ask along with the other screenings that you're doing. So today we really were focused on social needs questions, but if you are already doing the depression screening, other ACE screenings, maybe that's the right time to ask some of these other screening questions. And really ultimately, where can you make an impact? So if you go to the next slide, Health Leads is an organization that's been doing this work for about 20 years. And they are just one example, but they've really distilled down kind of the essential social needs domains. So if you don't know where to start, these might be some places to start. And if you think about the hierarchy of needs, these are pretty critical. And often there's resources to help families with these things. So this might be an area that you start. I will say that if you're going to do financial resource strain, if you ask a question like, do you have enough money to make ends meet? I think we all have a different scale of making ends meet. So just be aware of that. There's a lot of false positive rates with those type of questions. And while we didn't talk a lot about exposure to violence, you also want to think about your workforce and what answers they might get from screening and whether or not they are ready to take on, answering those questions or doing referrals. And I will get into workforce in just a couple minutes, but really thinking about what are the right domains. And this is just a starting point, but it's kind of a good starting point if you're trying to think about where you might want to start. Next slide, please. Overwhelming. I think Dr. Davidson gave us all the list of screening questions and the different social needs screening systems. And I love how he pointed out that half of them out there are kind of homegrown and then half are following a validated survey. But I think some common rules to follow are really to keep your screening short and simple. This is overwhelming for families to answer these questions, whether you're doing it via paper form or asking the questions, and I'll get into that in a minute. If you are having families read the screening questions, consider a 5th grade or lower reading level. Be really inclusive of everyone that you're trying to screen for. Really think about the prevalence of need versus whether or not a family wants help addressing the needs. We've run into this a lot where you might screen and a family says they have this need, but they might not want you to help them with it. And so there's a balance there that you want to be thinking about, and then also thinking about whether or not the screening is strengths-based. So don't approach a screening form with what's wrong with you, but rather what has happened to you or what's happening to you. So really strengths-based. And then you also want to think about, you might have a screening question, but then of course there's follow-on questions if a family actually answers, yes, we have a challenge with this. So just to be thinking about that. And then we also, just make sure that you can have these screening questions in multiple languages. I know in Dayton, we have our screening form in both English, Spanish, and Russian, because those are the common languages that are spoken here. So be really thoughtful about the cultural competency of your screening questions. And here again, involve those that you're screening in this process as you build it. You'll get better outcomes as you involve them in your work. Next slide, please. I think the big question is, will I make my patients uncomfortable? And Dr. Davidson really talked about the value of trust and how this is all about building trust with patient families. And I think that, we've found that physicians are trusted, and therefore asking these questions is not something that parents have shied away from, at least in our clinic. And we really try to value and say we're building upon the trust that pediatricians might have with their patients in asking these questions. So, but we know at the end of the day, we're all worried about whether or not, we're going to make our patient families uncomfortable. So you want to first think about the workflow and your workforce. In our clinic, we actually have the paper form and the families fill it out before they go into the clinic room. That may or may not work in your area, but there has been research done that there is higher completion rate when a family completes the screening form on their own, whether or not they're being asked the questions whether or not, they answer it on their own instead of ask the questions. And if you think about it, if I'm a mom in the room and someone's asking me these questions, I may not want to answer these questions with my child sitting right there. So just something to think about. Also think about your workforce capacity and skills. It does not have to be the physician who asks the questions. It can be an MA, a nurse practitioner, a nurse. It just depends on your work team and what seems to make sense. You do want to be consistent so that social needs questions become part of the routine visit. So if you have families that are coming to you every month or every year, the first time you offer these questions, maybe they don't want to take it. But once it becomes routine and you're consistent about it, they'll say, oh, this is part of our patient visit. That makes sense. You want to frame the questions in a positive way. So things like, we know these things can cause you stress and we just want to be able to help you. Another article just came out I think last week or the week before, about explaining why you're asking the questions. We're asking these questions because there might be resources that we can help you with. It really helps put the families at ease. And then also, you might get a screening form, and if you're asking 5 or 6 questions, they could all come back positive, and that is overwhelming for families. So you might actually have to work with families as you address their needs and have those families prioritize their needs based on their values and their own goals versus you putting your value on what they should work on first, so to speak. So that brings us to the next slide. This is really the big challenge, is thinking about how are you going to connect families to resources. So, okay, you have a screening form. What are you going to do with that information? And you need to think this through from the beginning. And so don't just screen for screening again. You need to figure out how you're going to follow up now that you know this information about the family. And so, first of all, utilize existing community resources that are already out there. I think it's really easy for us to say, oh, we need a resource guide. And while you need someone in your practice to own whatever resource you're going to use or give, there's a lot already out there. So as I mentioned, Aunt Bertha, United Way 211s, even just going to your county or city government sites, there's a lot of resources there. So start there, because updating a resource guide is actually very time and energy intensive. But now, as more and more organizations are doing the social needs screenings, there's a lot more kind of social service databases out there that are tailored to your zip code, or your patient's zip code. You also want to think about whether or not your organization is going to refer. So family screens for food insecurity, and I could hand that family just a piece of paper that says, these are all of the food banks in your zip code, go forth. And that would work. And a lot of organizations are doing that. Depending on, once again, your time, your energy, your workforce, you may want to follow up and find out whether or not families did indeed do the referral and whether or not they were able to, once again, go and get the food and then think about that. There's a lot of work involved in that. So, once again, just dip your toe in and then you can build on it. Once again, I cannot underscore enough the importance of cultural competency and making sure not only are the clinic and the questions you ask culturally competent, but also be thoughtful. If I give a resource for a family who speaks Spanish, will that nonprofit be able to help that family who speaks Spanish? And that gets complicated, and I don't want to overwhelm anyone, but it's really important to make sure that the resources that you give are going to be useful for families. And then finally, I know this is probably easier for a healthcare institution, but really think about building some relationships with key organizations that you intend to refer to. So we have really good relationships with our food bank, and Dr. Duffy pointed out some of our relationships that we have. But if you know that you're going to be screening for food insecurity, you may really want to build a relationship with the local food pantries so that you kind of have some two-way communication. They understand that you're screening, they understand that you might be referring more families to them. And it really can make almost that warm handoff for families so that the outcomes are better for families. Next slide, please. I think we all want to make a difference, right? We don't want to do this work if we're not going to make a difference, but how will you know? And I think it's worth putting this up front and building this into your process as well. So, how does this work inform your practice? And we've found here at Dayton Children's, I've had anecdotal, just kind of conversations with physicians that say, now that I know this about patient families, it kind of changes the conversation that I have with them so that while it's really important to talk about helmets, if that family doesn't have food on the table, that helmet conversation, bicycle helmet conversation isn't quite as important. And so it's really interesting what kind of reflective work you can do as a practitioner as you're learning a little bit more about the context in which your families live. And it might change some care plans as you go along. So just something to think about if you're reflecting on the work and understanding families a little bit differently. You also might want to think about just consider tracking key metrics, especially for those of you that are really interested in quality improvement. We track things like number of patients screened, a number of patients connected to resources, number of screenings completed, just to make sure that we're keeping really good quality in the work that we're doing. This type of work is absolutely ripe for continuous improvement. And we are always looking to improve our processes as new questions come out, as the medical records allow, or the electronic medical records allow us to do more. We're constantly changing our program, and you'll probably see that happening in your practice as well. And you really want to think about too, who else might benefit in your practice from knowing this information. So it really allows you to strengthen really the care that your entire team can give. So, for instance, if you have a care coordinator, and they may or may not be part of the actual screening process, well, they're going to need to know that this family has problems with transportation so that they can help that family get transportation the next time they have an appointment. So really think about how you can utilize the data around families appropriately, but also to really make sure your entire practice can support that family. And then finally, once again, we don't want to lose sight of families and where they're at in this process, and ask them, is this something that you see value in? Is this something that makes sense for our practice to do? And to get their input on the process, it'll strengthen that in the long run. So finally, I wanted to be short and sweet here to wrap up. But I really think if you go to the next slide, Haley, just to know that the social needs screening is an evolving field. As the two speakers before me pointed out, there's a lot of literature that is exponentially coming out about what makes sense as far as screening, what screening and referral really have better health outcomes. So there is an evidence base being built. We're really trying to understand, once again, the interplay around child abuse and social needs screening and referral. So there's so much work to be done and continuous improvement to be done, but hopefully, you can take at least that first step and figure out just like one day in clinic, one physician, like start small, but start, because there's a lot of work to be done. You might just really think about one social need that you want to impact. And I think we've, the jury is in around food, maybe being that element that you can impact. And then you can really use this work for a quality improvement in your organization and in your practice. So we hope today that there's a lot there. You could try to boil the ocean, but hopefully if you just take one or two key steps, you can start addressing social needs in your practice. And then together we can make a really huge difference for the kids that we see. Thanks.
Thank you, Jessica, for that. So with that, I think we are close on time, but we're not over just yet. So I will go ahead and give maybe a quick overview of a couple of Ohio AAP programs, and then encourage everyone, if you have questions, to potentially send those in the chat. I don't know if we'll get to discuss them with the goal of getting you all out right at 4 today, but we will try to answer those questions, even if we don't get the chance to do so live here. So a couple Ohio AAP programs that address social determinants of health or other kind of related issues. The first is our Injury Prevention Plus Seek or Safe Environment for Every Kid program. And some of you may be familiar with this work that occurred a couple years ago. We're excited to be launching a third wave of the program in January of 2021. And this is a QI initiative that will combine the Seek screening tool for social determinant of health and other needs with some Ohio AAP injury prevention screening tools. and is focused on children birth to 5 years of age. We will be providing screening tools as well as resources to practices so that they can take that first step and also earn some QI credit. So from the ABP, this will be a project that counts as MOC for QI credit. We're really excited that in previous waves, all of our participants at the end of the program felt more confident in the way they could address social determinants of health and ACEs. So we're looking for up to 10 practices, and I've put my contact information in here. If anyone's interested or knows of a practice that's could be interested, we'd love to share that. Second, I'm going to highlight our parenting at mealtime and playtime program. I know we just mentioned food could be one of those areas that might be low-hanging fruit to kind of approach and try to help families with. Our PMP program is our nutrition-based quality improvement program that has recently shifted from QI to more of an education-based training program. Our first PMP education training is actually happening tomorrow, and we're very excited. It will focus on navigating through flu season and COVID-19. So talking about supporting well child visits, practice management, and some things during this kind of unique time that we're encountering. The next training will be in December, focusing on wellness and the importance during this time frame. So the link is here. We'll also include this in the follow-up if anyone's interested, but we do have one of these trainings less than 24 hours from now. So if you are interested, definitely please sign up, and we'll be happy to have more attendees to learn about that topic. Finally, the Ohio AAP's updated resource page. We've highlighted this, I think, on every one of our webinars in this series, but our online education, where this will be posted as well as previous trainings are posted, is the Pediatric Education Center. We have a family resource page that's actually connected to the SEEK program, and a COVID-19 resource page. And again, we'll send the links out following today. So with that, we're right under 4 o'clock. I will pause for Dr. McPherson or anyone else from our speakers if you have closing thoughts that you'd like to share.
Thank you, Haley, for explaining some great opportunities being sponsored by the Ohio AAP chapter. Thank you to all of our listeners today and learners. We appreciate your attendance, and we hope that we've been able to learn together some of the great resources, the theory, and the application of social determinants of health and how we can utilize those in our practices so that we can better the lives of the children who we come in contact with. And finally, one last thank you again for the Ohio AAP in sponsoring this series of 4 webinars on child maltreatment and child abuse prevention. As Haley said, the 4 webinars will be available for online viewing, and many of them are great resources for other people in your organizations to view and review. So with that, I think that wraps things up. Haley, do you have any other last comments, or any of our speakers, any final thoughts you'd like to share before we officially close this?
I will thank you, Dr. McPherson, for helping us with all of these presentations, and for kind of helping guide us to some of our great speakers, including those for today. And a final reminder to everyone, we'll send an email with the information for you to claim your CME and kind of give us any feedback on today's session. So with that, I think we can close, and thanks everyone. Have a great afternoon.